Welcome everybody to another webinar of Teachers Connect. And we have
Thank
had
you,
very
ma'am.
interesting discussions in the last webinars where there was a lot which was discussed about the best forms of teaching in the OPD and OT. And we are waiting to hear what the consensus report says, which Dr. Rashmi Jain and Dr. Priyanka Sudani will tell us soon. And now today is a very important topic. Apart from these consensus reports, we have this topic of wet lab, which is usually not talked about much. And this is something which a lot of people have been asking for. In fact, that is what WAS always does. Whatever comes from you, that is decided as an activity of WAS, because WAS is a society which belongs to all women ophthalmologists and, of course, to men also as advisors. So whenever whatever advice that comes from or suggestion that comes from women as well as men, and that is taken up, and that becomes an activity of WAS, and hence this wet labs became an activity of Teachers Connect program. And we welcome you all, and we are waiting to hear what a good wet lab could be, and that is why there are several presentations. One presentation is by Dr. Deepak Mishra, and after that, there are several of videos of Pet Lab, so that we can come out with. I'm sure all of them are going to be good, but we can come out with whatever is the best form of a wet lab in your situations and your circumstances. So, welcome all the ladies, and welcome to all the men also who are here. I can see Dr. Mahesh Babu and Welcome, Dr. Mahesh Babu. We are very happy to have you here. Dr. Mahesh Babu is a is a has been contributing to the WAS Teachers Connect program in a great way. Thank you so much. And
Thank you, ma'am.
we have Dr. Subhash Dadia also. I just saw him. Thank you. And we always start by thanking the men because they are a great support always to Women Ophthalmology Society, and we are here because of you all. Thank you, Dr. Subhash. I can
I
see
I
you
have
now.
asked today to all the residents to become member of WOS.
Oh, how nice. That is the whole spirit of good men advisors that we have. And thank you so much, Dr. Suvash. And so over to Dr. Maya to get started immediately with the session now.
Thank you, ma'am. And I welcome you all at the second session of the Teachers Connect by WAS. And today, as ma'am said, we have a very important talk on wet labs by Dr. Professor Deepak Mishra. And as a special guest, we have our WAS president, Dr. Madhu Baduria, ma'am, Dr. Namrita Sharma, ma'am, Chairperson Scientific Committee IOS, and Dr. M. Vanathi, Editor IGO. Also, as moderators, I, along with Dr. Swati Tomar, Dr. Shweta Walia, Dr. Sugneshwari, and Dr. Ragini Parekh are there. We have our esteemed panelists, Dr. Dadia, Dr. Srinivas, Dr. Ulka Srivastav ma'am, Dr. Mahesh Babu, Dr. Archana Vare, Dr. Devang, Dr. Jayashri Singh, Dr. Kavita, Dr. Pragati Garg, Dr. Rupali Chopra, and Dr. Sonam. So I welcome you all, and we start with the first talk of on wet lab, that is by Professor Dr. Deepak Mishra. He is a professor at RIO BHU Varanasi, and also the member ARC from Central Zone AIOS. And we all know that he has been conducting SSTC for so long time, and he's the most the best person to talk about how to set up a wet lab, which is a very integral part of all the teaching institutes who are conducting PG teaching. So I welcome you, Dr. Professor Deepak Mishra, and we over to you for your talk on setting up a wet lab.
Thank you, Dr. Maya, for the wonderful words, and thank you, Murta ma'am, for giving me this opportunity to interact with you all. Is my slides visible?
Yes.
It's moving. Just a minute.
So he is getting ready with the slides. Dr. Deepak Mishra has also promised to us that after this session, whoever wants to set up a wet lab, he will provide support in any part of India, and he will be there as a constant support to set it up till it is set up. Thank
So,
you, Dr. Deepak, for this promise.
thank you, ma'am, for all these things. I have no financial interest, although for the help of the other residents or the faculty who are planning for the different wet labs, I will name few companies or advise something who will give us at low cost equipments and sutures and other things. First of all, why wet lab is important? We all know that wet lab is the building block for the any surgeons, and all of us underwent some training. Means either on the gloves or the suturing, and there will be everything we also did at our time. And nowadays it is more uniform, and as per the various guidelines and the norms of the different regulatory bodies, either NBE or the NMC, everyone now prescribe that each institute or the whosoever is the teaching institute and even the fellowship institutions also have a wet lab curriculum for their PGs or for the post PGs. One of the important thing means why these wet labs gives us what advantage. One thing is it helps us to attain the skill, and that skill, if we are doing any surgery or anything on the live patient or the human patient, then we have a lot of anxiety or the tension, other thing. But if we have done these things, means we practiced in a non-living things or the environment which is a risk-free, then it will be much better for us. And before attending or going for the any surgery or anything which is on the life, if we gain much more confidence on that by doing this, it will work a lot. So I have divided my topic into the 4 different headings, means what are the requirements, what are the things which we need to do for the setting of these wet labs and other thing. One thing is the space, means most of the time when we are going here and there for the any places, people want means, sir, what is the space? Means we don't have space. Even the major institutions don't know. Some of the colleges and different they don't said we didn't have space in our department. What we can do? So I will decide something and guide you all that what space is sufficient. Another is the requirement for the consumables and equipments, means what are the basic consumables we can have in our wet labs and the equipments. Third is the curriculum, although it is a very much variable, means it depends upon the courses and the surgeons or the equipment institution wise what they want. And fourth is the cost, that is the most important thing, means most of them are showing or having interest, means how costly it will have to have a setup of the wet lab and other thing. So I will go one by one in all these things. So, based on our experiences of more than 10 years for doing SSTC courses in EIOS and different forums, even when Nadia sir was the secretary and president, he has given us opportunity to do it in the DOS and Mohita ma'am in WOS. Everywhere we did SSTC. So my suggestion is if anyone is planning a wet lab, then first important thing is it should be in the main hospital building. Main hospital building means if it is in the department, suppose our department is usually like that, most of the ophthalmics setup it will close at the after the working hour, minus at morning 8 to evening 8. And this time resident and fellows are busy, so they cannot do wet lab in that time. So if it will be available in the hospital or the ward side, or if it is attached with somewhere they are doing the night duties, it will help them a lot because they can go anytime. Means if space is such a in a such a place that a 24-hour availability is there, then it will work much better for them as compared to it will be in a closed place which will be will be available only as the working hour. And second thing, if it is possible, then at least have a space for the 2 persons. 2 persons, why I'm saying that every time, means in the initial time, whenever anyone is doing the wet lab training, then there should be one trainer because doing anything without guidance is just like we are practicing by own and don't know which step we are wrong and where we have to correct it. So the ideal size or the room for the wet lab is ideally a 10 by 10 feet. Means whatever is the room, that is 3 by 3 meters room, is more than sufficient. I am showing you few photographs. Means this is the ideal setup. Here if you get a room of the 10 by 10, then what are the things we can put it easily for the wet lab. Even if we want a monitor screen, then we can put a one monitor or a whiteboard can be placed here. Another is if we want to do it phaco or any vitrectomy machine there, we can place easily vitrectomy and phaco machine. One microscope, either it will be a table mounted or some old microscopes which usually used, and these are the two revolving chairs. These can easily be fitted in the 10 by 10 rooms and it has more spaces. Means we are seeing it only two wall and third wall can be used as a storage, means an almirah or other thing which we can put it in this room. I am showing some more pictures, live pictures. This is the pictures we have planning wet lab courses in VIVS each and every year. Here you can see the same thing is stimulated here, whatever we have, and these are the places, either these boxes are there where we can put our almirah. See this here very comfortably. This trainee trainer and we all are sitting here and there is no space crisis. And if we are going for the 5-6 resident, means one batch of the resident is having 5 or 6 residents and doing one is doing surgery and another is watching by them, then easily this 10 by 10 feet rooms can accommodate almost 6 to 7 residents sitting with all the equipments. So our suggestion is if we have a 10 by 10 room, means it is easily available. If we can plan, we can have a places. If it is not available, then even we can make a artificial space by the nowadays aluminum partition. We can do any corner of the room or any uh, side of the your hospital or the clinic and make it as a 3 meters by 3 meters. There is aluminum ply is always available. You can put it and make it in such a way that if anyone is watching and planning for the wet lab for their own state conferences or other thing, then they can make it like this also. This is the wet lab pictures we have done in the ISCKRS. Here you can see it is an open wet lab. It is not the closed wet lab. So even but for the conference purpose, it will also work. Means, but here also the distance between two tables you have to maintain at least the 1 meter distance so that another teaching program is going easily and it will not affect the another one. So space is covered. Now coming to the consumables. Listen, consumables depend upon the two things. One is the nature and the type of surgery which we are planning, means SICS, phaco, vitrectomy or trap. And another thing is number of persons are the trainers. Means if we are going to plan for 6 residents or 8 residents, then we have to multiply or divide in a such a way that it can goes. Means one our knife can do surgery for the wet lab purposes for 2 to 3, which we do. But visco is we have to put one by one because they are doing surgeries and beginners, they can use lot of the things which are the consumables. So the common consumables which we have to maintain each and every time is the sutures, whatever the sutures you are planning as per your surgery. Nowadays PK, even DSEC, DMAC, everything is done in the wet lab. So you can plan sutures according to that. Knives and the fluid, that is the important thing, means you have to maintain the fluid if you are going for any surgery. The things in the consumables is the material on which we can do or the practice this wet labs. One the important and most easily available is the goat size. Goat size is available each and everywhere. Even in the mess, most of the residents, I know many of them have set up their wet labs in their rooms and other thing with for the practice of a small pulses. They can ask their mess manager another and they can bring them the goat eyes on every Sunday because of their dieting schedule or the mess schedule. You can use banana, apple, or even the thermocol planes. So these things are also available easily. These are the things which I have shown, means we can do your suturing or whatever the practice in anywhere. This is the important thing, that is the wax size. This is available particularly at the few distributors, means few pharma companies in India. Madhu Surgicals are providing this wax size for there, and this is used basically for the phaco. But for the SICS, trab, intravitreal, goat eye is good enough. For the practicing of the sutures, thermocol, banana, or even the gloves can be used. Now coming to the equipments, one thing is important, means whatever the microscope we are using, at least it's have a side view or have some old TV or the monitor, or nowadays old department computers desktop can be attached with this. It will help to see the trainer, because until unless the trainer see your exact position and your surgery, he or she cannot guide. Our surgery is basically dependent on microscope. So trainer view is very much important. And one thing is also important is in the wet lab too, you have to put some dustbin which is as per the norms of the garbage distribution with color coded dustbins. Why I am saying this? Because most of the places when I visited and taken the feedback, even from the senior faculties, they said we set up a good wet lab, but resident throw each and everything here and there. Sometimes they don't wash the equipments and other thing. That is the most common problem which are seeing in which the places we are moving. Means any institution, any faculty or anyone can buy one at a one time or two times, but it's the responsibility of the trainee who are doing to maintain this. Means until unless you maintain, it will not work for you. Another thing is whatever the surgical equipments, again, I'm saying it depend upon the which surgery we are planning to do it. Something which is important for these equipments, means without that it is not possible. One is the thermocol ice box, because when we are getting the goat side, usually we will get in the morning or in the afternoon, and we will try to do the surgery 6 hours, 8 hours later, then these goat eye will sunken. So if it will be put in this thermocol ice box or the refrigerator, it will be in a good hydrated state. And that for the phaco, it is sometime advisable that if we are getting the goat's eye, just microwave it for the 30 seconds for the 50 or 200 degree, it becomes hard. The goat eye becomes the hard, and you can do phaco on this hard ice. This is the storage almirah or the storage box is important. What I have already mentioned, that if it is possible, means after each and every time when you are doing in the both side and other eye, there is chances of infections from the viral disease and other things. So use proper gloves, clean your equipments and store it in almirah. Because it is not possible that every time institution will provide the resident new sets of instruments for these wet labs training. So maintenance is important. And one thing again, I am saying you that I saw many of the places, the wet lab, and they have put a single chair and the table. So only problem is that if your table or the sitting chair, at least one should be movable. Because when you are doing it in surgery in the microscope, you have to set yourself to. So for the proper sitting arrangement, moving system, it is important that even the stool which we are seeing are the chairs, it should have some adjustable heights, and the microscope, if chair is not possible, then the table at least we are using. Most of the time I advise people that if you have some old table with the equipments, means like NCT or RF, autorefractometer, which is you are not using nowadays, you can use that table too, which you can move easily. One thing important is if we have equipments and material, but how to fix it? For the fixation, there are 2-3 options available. One is this type of manicures available, which is a plastic based, and here you have seen the screw. This can be tightened every time, and at each and every time you have seen that now this eye ball wax eye is fixated, and you can do any surgery and it will not move. Another option is these metallic balls. Here you can fixate the goat's eye easily. Here you have seen it looks like simple, but it is slightly heavy metallic ball and it will not move during the surgery. And there is this fixator. This black point is a fixator which you have a hole here, and you put it and fix it the goat eye here, and you can do any surgery. Sometimes, like if you are doing interpreter and other thing, then doesn't require much. These are the places we, behind my tape is we are using just a simple board pins. So you have to take some portion of the sclera, which is apart from the eyeball or the muscle attached with this goat's eye, and you simply put a pressure with thermocol box, stabilize it, and then you can also tape this. So these two, three are the easy options available for anyone. Even resident can do it on their table or the room, take a thermocol and paste here and do the practice whatever they want. This is the special design equipments. We plan it under the guidance of Professor Madhu Muthuria when we did it, our GSI wet lab in Lucknow. Means ma'am wants that it should be in such a way that we can attach with on the slit lamp, and the resident can practice this applanation tonometer. So this and the previous one, means the one before goat eye stand is the same, but only advantage of this is it is having the lateral fixity also. That was the only the vertical fixation where we can do the SICS or we can see the goat's eye from the upside. And here you have seen that it is easily fixated on the slit lamp, and anyone if you want to do a applanation, we can do and practice this easily. Now coming to the wet lab curriculum, although it is different and customized according to institute and everything, but I'm just suggesting a wet lab curriculum for the cataract and the phaco, because most of the wet labs training and these are done nowadays for the cataract surgery. So the first year should have at least 3-4 important knowledge. Means first of all is the adaptation and the practice on the microscope. Means they have to know what is the requirement and how they have to fix it. Otherwise, what is their IPD, how they can see everything. And again, at least they can use make sclerocorneal tunnel, do lot of thermocol or suturing practices, and try to insert and use cannulas, aspirate, side port, making dye. These are the things we can go easily for the first year. For the second years, they if you are not doing that, they started making the capsulorhexis, whatever the procedure almost inside the eye, we can say either capsulorhexis or prolapse or the viscoelastic or the that one cortical wash they can do. And the third year, they not only do this wet lab, but if they are doing a phaco, then they have to know and understand their phaco machine also. Means what is the bottle height, how they can prevent the wound leak, and how they can go that. So these are the stepwise curriculum. We can plan it these and different for their own institutions. Now coming to the another options, means for the wet lab nowadays there is a lot of craze for the simulators. There are two types of simulators nowadays available for the cataract surgery, and some is having cataract with VR facility also. One is the VR Magic. It is they are having cataract and vitreoretina, and now Help Me See is also having. They have the SICS software, and now they are having the simulators for the phaco and somewhere. But one thing is important that these simulators are the little bit costly, and it is not possible that each institution can buy it. So what we can do if we don't have these simulators, either we can get grants from the government institutions or from the government agencies to get it. If not, then what I can suggest is we can collaborate. If anyone is having these simulation machines, then the other medical colleges or the institutions level to that area, they can collaborate and they can easily learn here. These simulators are good enough. And also there is opportunity that some pharma companies are giving opportunity to send you to the labs or the different places where these simulators are there. So you can also, your department can also tie up that they can sponsor or help your resident to go and get trained on the simulators. Another is the cost cutting tips for the whatever we can plan or the have a go time. For the FECO machine, I always advise to give the, if fresh one is, everyone is knowing that not possible. So older equipments are the older FECO machines which we are, means after buying 2, 3 new, it will be just like a refurnished. If we can get, it will be a good options. Another is the microscope. If we have an old microscope in which light and depth is good, we can use it. And if not, then the important cost cutting we can make it means after at the cost of 50,000 or the 1 lakh nowadays, table mount microscopes are available. By it is made by many of the companies. They have marketed it as a portable microscope where you have a 2 or 3 screw and you just um, unfold it and screw it on the table. Another thing is if these microscope or table mount microscope is difficult, then for the basic one, what we have used in the older days means there is a plus 10 eyeglasses or the plus 10 or the high power head mount glasses are available. These can also be used for the practice for the suturing purposes. And another thing, like the consumables, I am going to tell you 2, 3 things. These two things we always used means some expired sutures or the viscoelastics or the dye or the some remaining one from the left out surgery. But nowadays good options is by these RO labs and APPA, they are providing as the non-sterile sutures. Their cost is very much less. They are having non-sterilized sutures, blades, even visco and dye. So instead of looking for the expired or looking for the remaining ones, what happens to the remaining ones means they are having their needles are blunt or sometimes they are having very less. So for the beginners, it will be difficult to do the suturing with a shorter length or the blunt needle. But these non-sterilized sutures are just like the ideal sutures which we are using, and these materials and these options are available each and everywhere that we can use the non-sterilized things for that. This is our article for the setting of these wet labs. Apart from these, what are the tips I have given here? There are a lot of other options are available. If anyone wishes, they can go and read for it. So my take home message is one thing is the proper planning for the space, whatever the equipments and the cost is important. Nowadays, fund is not an issue because lot of the things available in the market at the low cost. But the one thing which is much important is the knowledge, means how to set up, what are the things available, from where to get these equipments, from where to get how to store these goat's eye or how to make them hard. That knowledge part is much more needed, but I think nowadays with these words, if anyone wish to set up any learned skill or any wet lab, my mobile number, email is here. I am ready to help each and everyone. Please be with us. And nowadays, what I can say, and I think Professor Dadia sir is there, Ulka ma'am is there. Everyone know that wet lab is the key factor for the learning. That only thing I can say. Thank you. Thank you, Tina.
Thank you, Dr. Deepak. It was indeed a very, very informative talk, and I think everybody would agree that in medical colleges, it's the need of the hour. We do not have enough wet labs and not even, rooms extra which are available to set up these labs. And as you said, that collaboration is one thing that we can come about. For quick comments from our panelists, may I invite Dr. Ulka, ma'am, to say a few words and please advise us more. Ma'am, you have to unmute yourself. Yes.
Thank you, Doctor. Actually, it is, as you said, it is need of an hour today. And one important thing is nowadays every medical college at least have a skill lab, and there you can find out the space to develop this wet lab. And definitely we should have all the things which are required to learn, and it is definitely a good thing to have this practice and expertise in these things, because beginner is not well accustomed with eye-hand coordination and all. For this, wet lab is definitely a better and definitely an important option. Another thing, one thing that that was covered in the lecture is that the disposal of the biomedical waste, that is very, very important, and one should take care of that. And second thing is that one should avoid any needle stick injury, because that is also that can occur while we are learning in the initial phases. So many times we do not pay attention to these things, these small things, but they should also be taken care of. So thank you so much, and we should have that skill.
Thank you, ma'am. Thank you, ma'am. My next question is to Professor Subhash Dadia, sir. See, GNEC is a very big this institute, and you have lots of PGs. I just wanted to know that how many PGs voluntarily go to wet labs and they utilize it. You have a big setup, so even in spite of the setup that we give to the PGs, there are a lot of disinterest that we see a lot of times. And do you also face these kinds of challenges at your institute?
Basically, in our institution, the PGs, they get a lot of opportunity to do the surgeries. So basically, we have to force them to go to the wet labs.
Right,
It is
yeah.
a challenge.
Yes, it's a challenge, definitely. And I think they are more interested in doing this. Definitely, it's an important step, like the first year residents may be more interested to, try out,
Second
especially.
year and third year don't want to go to the wet labs.
Yes, right. So, do you have a curriculum also in
Yes,
your
yes.
to of number of wet lab hours that every PG has to do, or it is open to this?
Basically, office orders are issued for the PGs to attend the wet lab.
Right,
And there is
right.
roster. There is
So, Swati,
roster.
Guru Nanak Eye Center is an institution where from first year everybody is operating.
Yeah,
So actually there is not much need of a wet lab only. First year will immediately start operating. But there are many other institutions where this does not happen. We find that the residents come out of the institution without learning. So
yes.
there is no comparison between this and other institutions.
Right.
Actually,
Yes, sir. Yes, sir.
Actually, I have been to various institutions as examiner or as a NMC inspector. So I have seen at many institutes, postgraduates, they don't have opportunity for performing the surgeries. So there it is. This wet labs are of should be of great help.
Right, sir. Dr. Mahesh, we would like to have your inputs on this.
Yeah, good evening, everyone. Actually, we have a basic wet lab in our medical college, and we are in the process of upgrading. And I think this talk was up for the time, and I'd be needing Dr. Deepak's help in this. We basically have set up for this SICS, FACO, and other suturing things. And our protocol is like we'll ask our PGs whatever procedure they want to do on patients. Before that, they have to do on in wet lab and record the videos and show it to the mentors, and that will be reviewed like multiple times and corrected over there. Once the teaching faculty is are happy, maybe they approve that the process or whatever surgical steps they're doing in an appropriate way, then only we allow them to do on actually patients. So in this way, we are able to reduce a lot of complications on patients, and the enhancement of skill of the PG is also very good actually. And maybe from first year itself, they can actually start doing on patients, maybe the simple SICS, pterygium, sac surgeries, and all those things. So I feel this wet lab really plays an important role, and maybe all the medical colleges uniformly. There is no uniformity across India. We have a number of medical colleges, but even I know many of my friends or PG's friends they discuss with others. There are many medical colleges lack this what we can say is wet lab, very good wet lab where they can actually practice But I feel there should be some uniformity whether NMC brings it or not. From our society, we can bring in some guidelines, minimum guidelines for the sake of training, because ours is mainly a surgical branch, not just refraction and glass. So something from your side and maybe from WO's side to bring in uniformity or guidelines would help all the young ophthalmologists. This is my opinion.
Hi, Dr. Swati. Dr. Modini here. Can I share from Telangana?
Yeah,
Can I share a bit?
please. Yes,
Yeah, so
please.
we have 34 MS students every year, and our alumni association is lab, that is Srini Devi alumni. Every year we have a wet lab course for the first years in SICS and for the final years in FACO. And other than that, when they are on night duty, we have people stationary on night duties, not call duty. There is a DMO, that is assistant professor, and a SR and PGs. So the DMO and the SRs go to the wet lab with the PGs and train them even on those days. Those are customized to their need. And we have a CME program of 1 week, which is where we'll run hands-on wet labs in almost all the subspecialties for all the postgraduates of our state and neighboring states who come. So I think space definitely, and a little bit of financial support, like Dr. Deepak was saying, is sufficient. Only you must have because it's a medical college, it is easier for me to do it.
Yes, ma'am. Agreed. I think it's a very good idea by you and by Dr. Mahesh also that, we should come up with some guidelines from the NMC also, and WAS would definitely be, happy to lay down with our extreme panel and a very good Dr. Deepak is here to have some guidelines, recommendations that we can send. Anybody else would like to share their experience of their wet lab? Yeah,
I
Dr.
would like to
Pragati.
share something.
Yeah.
Yeah, actually, if we have less of helping hands or consultants in any institute, we usually go by the normal pattern of observing. We teach the residents in a normal pattern like observership, then assist, and then do the surgeries. And if we give the resident directly the surgeries, then there's less of confidence, more of complications. Those things are there. So I think the wet lab is a must these days, along with the simulators, if possible. And if wet labs are not available, at least they can try the Rexace and capsule tunnel making on boiled potato, on onion peel, on bananas, as Dr. Deepak has said. These can be practiced on the suturing on a thermocol. These I always advise my residents to do all these practices at home, either with a loop, they can do that, or with a discarded microscope if anybody has that. And advice to the residents is always there that they should attend the wet labs and conferences. And nowadays, all conferences, they are arranging for the wet labs. And I'm really thankful and really appreciate that effort. And really, the residents are being benefited by it. That's my say.
Thank you, Dr. Pragati. We have Dr. Namrata who has joined us, and we would like to have comments from her about, the current scenario of wet labs which are available, because she has traveled throughout all the medical colleges in India, and we would like to have your expert comments, ma'am, on this.
And Dr. Swati, one thing is that AIMS is having one of the best wet lab which I saw
Yes.
personally. So, ma'am is from the institution which is having one of the world-class
That
wet
can
labs
be,
and
yes.
and the world-class training both on the live
Right.
and wet lab too. So, I think ma'am can guide us much
So
better.
that's a benchmark that, everybody
He's
would
having
like to
both,
follow.
which is an ideal for the ophthalmology training. Ma'am,
Right,
please.
right.
Thank you, Deepak, and thank you, WAS, for organizing this very important webinar on wet labs. Wet labs have become the trend of today, and I think they are here to stay forever. Earlier, I think the wet lab teaching was not given so much of importance, but thanks to the programs which are run by Dr. Deepak Mishra, Dr. Satanshu Mathur, and even at WAS by Dr. Mohita Sharma and many others, where wet lab has now become the norm. As far as RP Center is concerned, we established wet lab almost 12 years ago, and all the residents have to compulsorily do a fixed number of cases, which are about 20 in number, before they finally do surgeries on the human eyes. So they have to maintain a logbook, and it is primarily a wet lab which was developed by Alcon. So it has the phaco machines, it has the monitors, and you can do it on goat size. Plus, it has those molds of human eyes. So the goat eye is actually put on that, and then the surgery is done. And the surgery can be very nicely supervised by the person who's actually teaching, because everything comes on the screen, and it is a personalized screen. So one for one. So for one supervisor, I mean, for one mentor, one mentee, and one screen. So it is a one-to-one transfer. So I think whether it is for phacoemulsification or for SICS, it was started for cataract surgery, but now it has taken all over. I mean, we are using goat's eye to even teach squint surgeries, to teach intravitreal injections, to teach DALC, DSEC, DMEC, before finally these cases are taken up on the human eyes. And I think that is the way to go. I personally uh, practiced myself DALC as well as DSEC when I was in Moorfields and doing a fellowship. And there it was compulsory that you would have to do 5 DALCs or 5 DSECs on pig eyes. There you used to get pig eyes, and then you had to record the surgeries, discuss with your mentor, and then only he would allow you to do surgery on human eyes. So it used to be so strict. Of course, now we this is not compulsory in all the institutions, but I think some kind of a guideline should be there. And I think, Deepak, you already have SOPs for wet lab, so you should formalize it. Maybe we can formalize it at the platform of WAS only, so that all the other people also in the country, if they want to start wet labs, they can do it looking at those SOPs.
Sure, ma'am. Sure.
Yeah, that's a great idea, in fact, ma'am. And I think keratoplasty and other surgeries, and even in the fellowships, they say that you have to do 20 keratoplasties and the suturing technique, and then they are allowed to operate. So I think it's a major this. We have Dr. Sonam Verma from Indore. Ma'am, you wanted to say something just to add on to the discussion. You have to unmute yourself.
Sonam is muted.
Hello, am I audible?
Yeah, yeah.
Yeah, so mostly in OTs, what happens is we are doing things at speed which suits us, but that time asking a resident to observe and learn at the same time, it's little bit difficult for the first years and the beginners. And even when we ourselves go for any updation, so in the OT in the real time, it is bit difficult to follow. Whereas when we do the same thing to teach them in the wet labs, it gives them enough time to process the step by step like finesse of the steps which are required for particular procedures. So there also for making the things go in bit of slow motion, wet labs play a good role.
Sometimes
Yeah.
I feel it is easier to do surgery on human eyes and more difficult to do in wet lab situation. So if you are actually able to do in wet lab situation, you are going to find it easier only, in a real situation, because
So for us, it is
everything is
easier.
tailored there. Your instruments, your viscoelastics, everything is the best there. But in the wet lab, everything is the worst. I mean, everything is discarded from the main OTs is used in the wet lab, which actually should not be like this.
Right,
No, for
true.
the person who's getting trained, for them, I was trying to say.
Yeah,
For
yeah, yeah.
them,
Yeah.
Yeah, for
getting
them, the mental piece is much more, because what can go wrong? You can't do anything wrong with the animal eye or with the synthetic eye.
I think another very good point Dr. Mahesh Babu pointed was a recording of these surgeries also. When you have a mentor allotted, they can go back and see and look and where what changes can be done with each trainee. So we move on now to the very nice videos that have been prepared by some of our speakers here. So wet lab videos, 2 minutes each. And the first video comes from Dr. Smriti Vipul from SNC Chitrakoot. Dr. Smriti, would you like to?
Yes, ma'am. Good evening, everyone. I'll be presenting the wet lab facilities at SNC, and I'll give you an overview how we conduct hands-on surgical training. I'll just share my screen. Ma'am, is it visible?
No, not yet.
Just a second. Now is it visible, ma'am?
No, Dr. Smriti. Yeah.
Okay. There's some glitch, I don't know, just. Now is it visible, ma'am?
Yes, it is visible now.
Okay, so here's the video.
Chikitsalaya, Chitrakoot. Education is not just about acquiring skills, it is about shaping responsibility, precision, and purpose. In the wet lab, learning becomes experience. Here we translate theory into practice and knowledge into confident surgical action. This video reflects our structured training in core ophthalmic procedures, from mastering suturing techniques to refining phacoemulsification skills for cataract surgery. Every session strengthens our understanding of tissue handling, wound architecture, and the importance of surgical ergonomics. We also engage in advanced hands-on practice for therapeutic penetrating keratoplasty, where millimeters matter and compassion guides every movement. The wet lab provides a safe environment to make mistakes, to learn from them, and to grow stronger, so that when we step to the operating theatre, we do so with confidence, clarity, and calm. Behind every careful placed suture is not just a technique, but a promise to restore vision, dignity, and hope. Under the mentorship of experienced faculty, we are trained to think like surgeons, to anticipate complications, respect tissue, and uphold the highest standards of patient care. Because surgery is not merely a procedure, it is a responsibility entrusted to our hands and our hearts. At Sadhguru Netru Chikitsalaya, the wet lab is where skills are sharpened, values are nurtured, and the future of ophthalmic surgeons are shaped. This is more than training. This is the journey toward becoming guardians of sight.
Yeah, that was a mesmerizing video. Very beautiful wet lab setup. I must say, very advanced setup at Chitrakoot. And I
Thank you.
congratulate Sadhguru Netralaya for that. And
Thank you
I'm
so much,
sure
ma'am.
that the residents must be benefited a lot.
Yes, ma'am. Yes, ma'am. Definitely. Ma'am, here soon we are getting the simulator as well, so that we'll get the actual feel of like the various modes of emulsification and all. Also, we use the discarded this thing corneal tissue for TPK practice, or like for basic suturing practice, for making the bubbles and all. So yes, definitely we get benefited from them.
And one thing, Dr. Swati, I would like to add, when I was there in the Chitrakoot last year for the PG teaching, they
Yes, sir.
developed some thing for the squint surgery, means how to
Yes, sir.
suture
Yes,
the
sir.
squint.
We
What was
did.
the name of that guy? I forgot. That
Sir,
you
actually, we have not named it, but ma'am, the this thing we use for beauty blending sponge. From with that, we have made a model for squint surgery
squint
practice.
surgery. They made
Yeah.
this cut this
With
blend
that
in a
beauty
such a way
blender.
that it act like a muscle and it having a good
Yes.
property of retraction also. So what was the
Yes.
major problem in the squint surgery is we lost the muscles or it will retracted.
Yes.
Anyone can practice on it.
Yes.
And
I think that's a very good idea, and you must, when we make an SOP or something, you must include all this, Dr. Deepak, to help others to also follow that.
One thing I want to add, ma'am, we can use the aluminium foil also for
for the
Rex's
practice.
practice. we just put the aluminium foil over the bowl or any katori we have in our room, and we can use for Rex's practice. We can use that for Rex's practice as well.
So these are the
Okay.
practical tips that the residents should, follow once they start surgeries.
Also here, ma'am, the discarded box of the Visco, the Appa Visca box we get, green thing.
That will
So
also.
it has got three layers. So if we are practicing, so we can practice by creasing the art of tunnel making on that discarded box. So whenever we give training to DNBs or first year fellows, we always ask them to use those discarded boxes for tunnel practice.
Dr.
Very
RC
good
is here.
idea.
She can give us few tips on the glaucoma surgeries because she's doing SSTC courses many times. And
Yes, sir.
Yeah,
So
Arshi will
basically,
be speaking. Arshi will be presenting the video. Yeah,
oh, okay.
right. So, may I invite you, Dr. Arshi? Are you ready with your video?
yes, absolutely. Just
Yeah.
give me a
So
second,
she is
madam.
from Guru Nanak Eye Center, and today, and she will be presenting a video on MATLAB.
So, Dr. Deepak, all those who are
See my
presenting their
screen, ma'am?
videos,
Yes, ma'am.
you could take them for helping with you for preparing the SOPs.
Sure, ma'am. Sure.
Is my screen visible, ma'am?
Yes, please go ahead.
All right. Thank you, ma'am.
Thank you, Dr. Arshi. So the thermocol suturing was the way that we used to do in our residency time. So that was nostalgic to see.
Yeah. So after the OT, they use the discarded ones, the suture ends that are left. If you use one and the other end that they use, and if they have any remnant scleral tissue or any of the sponges that are left over, they practice on it or the gloves material.
Definitely. So we have Dr. Veena Bhaskaran from Shankar Netralaya, and she would also be presenting a wet lab video of 2 minutes. Dr. Veena, are you ready with the video? Dr. Veena and Dr. Sonam. So any of you can unmute yourself. Yeah,
Yeah.
Dr. Veena, I can
Good
see you.
evening.
Right.
Yeah, I'll just share the video. Good evening, everyone, and thank
Good
you for
evening.
the opportunity.
Dr. Maya, it seems like a competitive session, the best video. Each
All
is better
are
than the
all
other.
are excellent. Yes.
Yeah, all are good.
Are you able to share your screen, Dr. Veena?
I'm just trying to 1 second. Yeah, just give me a second.
Yes.
You able to see the video?
No, not yet. The screen you are sharing, but it is blank. Can you stop share and share it again?
Yeah, I'm doing it.
Yes, now it is visible.
Yeah. Sorry, is the audio coming? I'm not able to get the audio.
No, audio is not coming.
It's kind of it's self-explanatory, and it's
Yeah,
the
you can speak. Yeah. Mhm.
it's the way we fix the vote eye to the mannequin. It's been rolled in a gauze after examining for the integrity of the globe. And then it is being fixed onto the mannequin. The sclera has to be exposed properly. And this is a wet lab setup where the student is practicing. This is moving on to the Hack Street IC surgical simulator. It's a high fidelity virtual reality platform which provides realistic instruments with the force feedback. And it also has a structured training module where the student performs. It also has good objective performance metrics with a good feedback. And they can do a number of times, practice a number of times on it. We do have a logbook for which the student has to enter in, and when they go out, the number of times they enter and the number of surgeries being performed. So once they get proficient in their surgeries, they move on to the real-time surgeries. So the other one is a HealthPC simulator, which we have procured recently, which is a flagship simulator for SICS. This is also well covered with a back-end instructor-led simulation-based training program with the classroom sessions and hands-on practice. The performance is also assessed by a master score, which gives a nice, which measures objectively the precision, tissue handling, instrument control, efficiency, etc. It gives good standardized competency assessment and surgical readiness before operating on real patients. Thank you so much for the opportunity.
Thank you,
We
Dr.
all say
Veena.
that we have to, the more you train, the more you sweat in training, the less you bleed inward. So that is the saying, and we ask them to train much. With all this, they get to train less because we have to force them in the second year, like everybody were telling, like they don't easily get onto the wet labs. So we have to make them do and certain number of procedures on wet lab so that they move on to the real-time surgeries.
Yeah, definitely. And I think even when they're in second year, they can, figure out what is the rate limiting step that few are having problem in Rexis, few are having problem in IA, and that particular step they can again go back to the wet lab and practice. It's not that they've started doing on patient's eye, so they it's not a thing that they should go back to wet labs. Anytime means
Yes,
even
yes.
us, if we are finding any difficulty in the surgery at particular step, we can go back again and learn.
Yes. Even all this Help Me See simulator, no, they've got even the complication management like anterior vitrectomies, pupilloplasties, CTR placements. They are all equipped with that. But this machine currently, what we are using is very good for SICS, and they are learning their SICS. They have to do at least minimum 10 cases before they move on to their. We do also have a Viva for them in SICS Viva, and then they go on to their real-time surgeries.
Very nice. So the last video is by Dr. Sonam Yanges from PGI Chandigarh. And I invite Dr. Sonam to present her video on the wet lab. Are you here? Yes,
Yes,
I can.
yes. Thank you, ma'am, and very good evening to everyone. I hope you're able to see this screen.
Yes.
Yes. Okay. So thank you, Woz, for this wonderful opportunity, and I'm going to start my video now.
This video gives an overview of wet lab training at the Advanced Eye Center PGI Chandigarh. At the AAC, we follow a stepwise approach to surgical training. After an initial foundation in ocular anatomy and theory, the residents progress to the practice phase, followed by the operating room training and structured evaluation. Our wet lab is equipped with phacoemulsification and vitrectomy machines, along with tabletop operating microscopes and video recording systems. This allows mentors to observe, guide, and teach effectively. For hands-on practice, residents train on goat eyes, acrylic and silicone eyes, and surgical simulator. A wet lab roster is circulated every Saturday. Residents practice on Madhu eyes and goat's eyes. The goat eyes are used extensively for ECCE, SICS, corneoscleral suturing, and extraocular muscle surgeries. Our MCH retina residents also practice sterile buckling on the goat's eyes. Our MCH cornea residents practice lamellar keratoplasty using research eyes on an artificial anterior chamber. Our wet lab training proved immensely important in the COVID era as well. The surgical simulator is divided into 4 graded categories, providing residents with a realistic step-by-step experience of phacoemulsification. Our recent work also highlighted the role of simulators in surgical training. More importantly, we have also developed innovations to support left-handed cataract surgery, enabling effective teaching even with right-handed mentors. Every wet lab session is documented using a structured evaluation sheet, which is routinely signed by the mentor. Residents who successfully clear Category D on the simulator, along with other training milestones, progress to surgery on patients. Cataract surgery roster is circulated on monthly basis. We have a dedicated resident cataract surgery table where the mentors guide trainees through each step of phacoemulsification. All residents maintain a detailed logbook and monthly audits are conducted to review outcomes and complications. We collect feedbacks from the residents who pass out on regular basis. As residents advance, they turn to become mentors for the junior trainees, reinforcing a culture of continuous learning. Thank you.
Thank you, everyone.
Thank you, Dr. Sonam. We have Dr. Devi Aishwarya Das with us. She is the state chapter head of WAS from Odisha. Dr. Aishwarya, you want to? Yeah, good evening. So we want your remark on the wet lab setting. What is your experience in your institute?
Yeah, so it is similarly, please excuse me, I'm not going on video. Yeah, so it's we have DNB teaching in our institute. So what we do is again like the thermocol thing and the suture material left over at day end. So we make it almost a ritual for them to go into suturing, though now they're more into SICs and DECO. And what we do is we make the mark semi-circular half, like 1/5 of the ring, like you would do in a EC section. And then initially they draw dashed lines and then they have to suture end to end. And that is how they go about suturing. And wet lab, as such, we do not get the goat eyes and all. So once they're into suturing, then they're into step by step into surgery. Cataract surgery.
Thank you, ma'am. And in the last Teachers Connect session of WAS, we had this polling and we had 2 rapporteurs, Dr. Rashmi Jain and Dr. Priyanka Sodani, who were the, who have compiled the results and made a consensus on OPD teaching and OT training for postgraduates. And now it is the time to listen to what consensus is made by them. So I invite Dr. Rashmi Jain to share with us the consensus on OPD teaching. You are muted, Dr. Rashmi.
Is my screen visible?
Yes, yes.
All right. And is it on slideshow? All right. Yes, I can see it's right. So, good evening, everyone. I'm audible, right?
Yes.
Yeah, okay. Good evening, everyone. So the first session of WOS Teachers Connect Phase 2, that started with the first webinar, which was on 10th December, with our esteemed office bearers, moderators, panelists, we had 2 talks for which I'll be giving a report, which were on what CBME means in daily PG teaching by Dr. Arundhati Pandey and practical tools for teaching in OPD and wards by Professor Dr. Kavita Bhatnagar. So the consensus report, which I'll be presenting is today, and this is for strengthening OPD-based ophthalmology residency training. So basically the key elements of CBME, which include defined competencies, focus on outcome, continuous assessment, documentation of learning, structured teaching sessions, and workplace-based assessments were discussed. The use in ophthalmology everywhere, right from clinical skills, surgical skills, and especially in soft skills and professionalism. Most ophthalmic competencies are learned in OPD, yet it was discussed OPD teaching is usually informal, variable, and faculty dependent. After the talk, 2 polls were conducted. The first was about the feasibility of various OPD activities and teaching in OPD and CBME. So it was the consensus which was reached, or what the opinion of the faculty was, that when it came to mapping routine OPD activities and documenting more than one supervised clinical encounter, everybody felt it was feasible. Here the green color represents the most feasible one, whereas the orange represents the less feasible, what everybody perceived. Whereas when it was about integrating communication skill, professionalism, and assessment in OPD, differentiating PG expectations by year, that means defining EPAs or defining milestones and end of OPD micro debriefs, it was not considered very feasible. A take-home message which I would emphasize is CBME principles are acceptable by all, but operational feasibility varies significantly across OPD strategies. So we all are happy with CBME, but how much we would like to implement is where we are not very sure about. The second poll was about how we can implement, which was after the talk on feasibility of practical teaching method. Here, as we can all see, creating rotating PG rosters for each year, having simple tips like teaching case of the day, use of digital tools, checklist flowcharts in OPD were considered quite feasible. Whereas when it came to documentation, such as daily PG learning logs, most people felt it was not feasible. Take-home message which I would take from here is faculty strongly favor simple, point-of-care teaching tools and organized restructuring, whereas documentation-heavy strategies are perceived as less feasible. This also came across in the discussions which we had, not just the polls. What should change in OPD training? Again, taking from a cue from some of the things we discussed as well as from the presentations which were made. Structure the existing OPD work using CBME. So map routine activities to defined competencies. Ensure at least one supervised cleaning encounter happens per PG per OPD. What do we prioritize? We should prioritize embedded case-based teaching tools. Such simple tips such as teaching case of the day, digital tools like images, videos, WhatsApp, and other things which can be simply done. Simple checklist flow charts while teaching as well as assessing. And finally, regarding assessment, introduce assessment and feedback in an incremental way. This is something which is always very challenging. So focus first on clinical reasoning and observable skill. Use very brief structured feedback moments from the OPD. Avoid overloading OPD teaching with extensive documentation initially. So the take-home message, or what is very important when we are trying to incorporate CBME in OPD training, is support faculty. This support can be offered through shared tools, webinars like this, and from local and national leadership. So that's a basic report which I prepared and I gathered from our first 2 talks of the last webinar. Thank you so much to WAS and all the members for providing me this opportunity. Thank you, ma'am.
Thank you so much, Dr. Rashmi, and that was so well compiled and very detailed consensus, and I must congratulate you for that. And I would say to Dr. Mohita, our secretary, that this should be taken forward, and this is very important consensus report, and this should I would suggest be published. Yeah, it would be
Today
very
itself,
helpful.
Dr. Maya, we have had a discussion, and Dr. Shweta will actually discuss with the rapporteurs and for for publication of these reports. And we had discussed in IG also whether this would be a feasible thing to publish, and they also feel it should be there. So let's see how it goes. But Dr. Rashmi, it does not end here. Now starts your responsibility of writing it in the publication form, and in which everybody who is present here will support.
Sure, ma'am. Thank you. Thank you so much for this opportunity. We'll definitely try our best. Thank you.
Thank you, Dr. Rashmi. And our second rapporteur is Dr. Priyanka Surani, and she'll be presenting the report consensus on the OT training of postgraduates.
Thank you. Good evening, everyone. I would be sharing my screen. Is it visible?
Yes.
So I'll be taking question-wise what were the poll results and everything. Just a second. So coming on to the first poll session regarding uniform faculty alignment to CBME, it was somewhat feasible for maximum 34. And the points raised were need for orientation sessions for faculty and presence of a CBME coordinator in each department. And the second, providing structured feedback without workflow delay. It was somewhat feasible again. Then the points raised were non-threatening feedback, tell us the way of giving a feedback, importance of CBDs, OMPs, bedside teaching emphasized, and day-to-day logbook entry of cases, even with feedback and reflections, was done.
Dr. Priyanka, your slides are not moving.
They're not moving?
Yeah.
It's moving here, actually. I'll again share.
Can you reshare? Yeah, please.
Now they're visible?
Yes. Can you make it on a slideshow mode?
It's okay.
Can you try moving the slides? It is.
They're moving?
No, not yet. IT team, can we help her with the slideshow? Do you have any other PPT? Means this is.
Maybe you can just read out and, just tell us.
Yeah.
Yeah.
So, regarding the point, it's not. Okay. So regarding providing structured feedback without workflow delay, it was somewhat feasible for 31 maximum candidates. And the points raised were like non-threatening feedback, tell us way. And then importance of CBDs, OMPs, and bedside teaching was emphasized. And day-to-day logbook entry and with reflections and feedback was the message. Regarding structured remediation plans for low-performing PGs, the peer discussion was on structured pre-surgical training, and it was very feasible and somewhat feasible. They were very nearby. It was somewhat feasible for 30 candidates and 29 very feasible. So stepwise teaching with different approach for all PGs and need for counseling to handle complications, inculcating ever-learning process, and importance of surgical and educational tools was emphasized. Then shifting from time-based competency to time-based to competency-based progression, it was again somewhat feasible only. The key points were departmental CBME handbooks, role of EPAs, milestones, and portfolios was emphasized, and it can be possible with structure, consistency, and teamwork. And PGs must know competencies to be in logbook, and milestone checklist for every year was emphasized by the peers. Regarding digital CBME documentation, it was very feasible by maximum voters. And then discussion point was Google Forms, digital logbooks with monthly reviews can be taken into practice. The second session result analysis showed for structured pre-OT briefing, it was very feasible with delegation of duties for supervision, different learning objectives for different caliber PGs. Local CBME task force in departments, again, it was very feasible, and forming evaluation teams and monitoring system. The discussion point was on CBME coordinator and delegation of duties, assigning mentors and supervisors. Step-wise surgical checklist, use of OSCAR rubrics, ICO OSCAR rubrics, and different approaches for differently competent PGs. And it was again taken as very feasible, and stepwise learning was emphasized, and standard checklist for must know and show competencies was discussed. Video recorded surgeries for feedback, it was again very feasible by maximum candidates, and discussion was on that novice surgeons needed post-procedural feedback reflecting on the potential improvement of the technical steps at the beginning of their training. It was emphasized on ever-learning process and not getting depressed, but learning from mistakes added with narratives. Counseling for depression after unsuccessful skill completion was also discussed. Use of mini-secs and DOPS during OT, again, it was very feasible by maximum candidates, and a word of caution was raised when work-based teaching in front of patients and importance of OSATs. And it was emphasized that these techniques help in evidence-based learning outcomes and improving supervisor training interaction. Regarding wet lab and dry lab before live surgeries, it was in consensus that these help, but there is a difference in virtual and reality, and according to one's resources, one has to make guidelines. And structured pre-surgical training must to bring uniformity, and wet labs and simulators were considered important to learn tissue handling, and fixed protocol for wet lab was needed. End of OT debriefs on complications and learning points, it was again very feasible by maximum candidates, and it was emphasized that it will enhance stepwise surgical skill, and it will minimize complications and improve management on complication skill, handling the complications. Regarding simulation tools, it was again somewhat feasible, and very feasible was nearby 30 and 28 votes. And low-cost simulators were also discussed, and initial hand-eye coordination, stereopsis, tissue handling problems can be managed by simulators and modelize was brought out. Competency-specific OT logbooks, it was again considered very feasible with discussions on digital tools, portfolio management, milestone checklists, and logbook validation. So key points with standardizing minimum core OT procedures, it was to bring uniformity in medical education, and issues of PGs not being given sufficient exposure to OT procedures were raised, and ICO OSCAR rubrics can be used in this case was emphasized. Last but not the least, it was emphasized that it's not the number of surgeries, it's the perfect step of surgery that was important, and PGs performing steps based on competency was taken as very feasible by all the voters. So very feasible at the end to summarize were digital CBME documentation, structured pre-OT briefing, local CBME task force, stepwise surgical checklist, video recorded surgeries, mini-secs, wet labs, and end of OT brief, and competency-specific OT logbooks, and allowing PGs to perform steps based on competency. And somewhat feasible were uniform faculty alignment to CBME, providing structured feedback without workflow delay, structured remediation plans for low-performing PGs, and shift from time-based to competency-based, and simulation tools. Thank you.
Thank you so much, Dr. Priyanka, for such a brief and very well compiled work. And as we discussed that this would definitely be part of, we'll request that this is published and, it is put to read to everyone else. With this, we come to an end to this very informative webinar, and I would like to thank Professor Dr. Deepak Mishra for taking out time and giving us a brief overview, and Professor Subhash Dadia and Professor Ulka Srivastav and others, esteemed panel, the speakers, our rapporteur, my co-moderators, Dr. Maya, and above all, our president, Dr. Madhu Badoria, and our secretary, Dr. Mohita Sharma, for putting in all the efforts together for this. And this, I think, the series that we are having right now with the WAS is one of its kind, which has been ever practiced by any society at large. And we really hope that this is useful to everyone. And with Dr. Deepak here, we would also like to have a promise that he would come up with an SOP and would help as much as possible in his capacity and others for setting up the best wet labs to whosoever who want to be associated with. And with this, I would like to wind up and if anybody, it's open to comments by anyone who would like to speak here. It's your own forum, or else we wind up. Ulka ma'am, you want to speak something? So you may unmute.
Just I will send excellent presentation and excellent videos and excellent this thing by this Rashmi and the other one. So it's a very good thing, and I congratulate all of you for making this a very successful webinar. Thank you.
Thank you. Thank you, everyone. Thank you so much.
Just 1 minute.
Yes,
Dr. Yeah. We have Dr. Aditi as a rapporteur for this particular session. And before concluding, we will take her statement on this session. Yeah, right. Dr. Aditi.
Thank you very much, Team WAS, for providing me with this opportunity. A very warm good evening to everyone. First of all, I will congratulate and thank for the wonderful presentations that we had this evening on setting up a wet lab for PGs. The main aim of this webinar was to emphasize our knowledge, approach, and the aspects of establishing a wet lab to enhance the surgical training and PG teaching. So there are a few takeaway points that I have made from this webinar, would like to share with all of you. The first is the dedicated space, operating microscope and standard surgical equipments along with audiovisual is required. And along with that, most of the training can be conducted using goat's eye. And if the institute has eye bank, then we can use the cadaveric eyes. We can go for enucleation, and those human eyes can be taken where the cornea is not suitable for transplant. The second thing is faculty supervision is must, because without supervision, the training cannot go good. So faculty supervision along with year-wise structured program for first year, second year, third year will bridge the gap between theory and the live surgeries. The third important aspect is handling of the tissue should be ethical and with biosafety measures along with the proper biosafety methods used for disposal.
Now first.
So at last, let us all take this pledge as PG teachers to establish and upgrade our wet labs for better surgical competencies, confidence of our PGs, and patient safety. Thank you. Thank you, WAS, so much for this opportunity.
Thank you, everyone. Thank you so much for attending.
Thank you, Dr. Aditi, for the excellent rapporteur report. And thank you all the speakers and all the panelists and the moderators. And herein we conclude the session, and definitely we are much more enlightened and upgraded, and we would be now taking up this task of setting up a wet lab in a better way at our institute. Thank you.
And we'd like to also thank Dr. Shweta for the main force and brain behind this webinar. Thank you, Shweta. Okay. Bye-bye.
Bye.
Bye.
Thank you. Thank you.
Thank you.